For our featured poster presentation today, I'm very excited to present our selected speaker, Dr. Paul Kennedy from the Towley Lab. He's a PhD and an expert in MR elastography. He'll be speaking to us today about simultaneous liver and spleen 2D and 3D MRE acquisitions.
Thank you, Sarah. Thanks for having me and letting me talk. So today, as Sarah says, I'm going to talk about simultaneous liver and spleen MRE elastography, specifically looking at 2D and 3D MRE acquisitions. We have some preliminary results. Yeah, no one's paying me anything. So quickly what we're going to do, a background of MRE. Some people here might not know how MRE works or whatever. Why 3D MRE is something we want to do, and then we'll go through the results we have currently and some conclusions we can draw from those results and some future directions that we want to pursue. So firstly, MRE, it's been around since the mid-90s, but it's only recently that it's been becoming quite popular in clinics. We do quite a lot of it here at Mount Sinai. It's been applied in any organ you can think of, but the main use is for staging liver fibrosis. So as you can see here, this is from our database. We have biopsy-proven F1, 2, 3, and 4. Morphological changes aren't so apparent on the anatomical images, but the stiffness is increased, and that's what MRE can give us, a measure of the mechanical property, which is shown as the stiffness. So I like to show this slide. It kind of encapsulates MRE in one image. We have a little phantom here on the bottom left that's being vibrated, and it has inserts in it going from stiffest to least stiff. You can see that how these inserts affect the wave propagation as they go through. So if we zoom in closely, we can see that in the case of the stiffest insert, the wavelength is being increased. And in the softest insert, the wavelength is being decreased. So in other words, when the waves hit a soft structure, they squeeze together. When they hit a stiff structure, they get stretched out. So what the algorithm does is it looks at these changes in wavelengths over spatial location, and it calculates the stiffness. So as we can see here, then what we call our elastogram shows very stiff here and very soft here. So this is in a phantom. How do we do it when we have a patient? So there's many different ways of doing it, as you might expect, but probably the most common way is from the Mayo Clinic, the people who invented the technique. So what we have is an external pneumatic driver which sits in the equipment room or somewhere outside the scan room, and just a simple plastic tube connects to a little drum here. So for liver, we place it just lateral to the xiphoid process, and for spleen, we place it on the other side, obviously, just a bit further down. So once we have the waves going into the body, we need to be able to image them. I know this is very messy, but I just want you to look at two things in particular. Here is the MEG, the motion encoding gradient, and here is a trigger time. So the motion encoding gradient is how we encode the motion into our images. It's synchronized to the external vibration which comes from that pneumatic actuator we just looked at. And what happens here is this trigger time, tau, is changed. So the onset of vibration and the onset of imaging are changed depending on the frequency that we're looking at. So what we want to do is capture snapshots of the propagation. So when we do that, we get something like this. So we have our magnitude image, which is just so we know what we're looking at. And this is the important one, the phase image. So even here you can kind of see some waves are going through, but up here you'll notice some phase discontinuity. That's just directly underneath the paddle, so we have very high amplitude there. But what the algorithm does is it unwraps that, and it gives us this nice cine image here. So we can see the waves as they travel through into the liver. The algorithm looks at these waves, looks at how the wavelength changes, etc., and it calculates the stiffness. But it does one thing better than that, which is very helpful for people like me who draw lots of ROIs, is it gives you a confidence map. So it measures the goodness of fit between the underlying mechanical model of the tissue and the actual phase displacements that we have. So why do we want to do 3D when 2D works pretty well? Well, one thing is that in 2D MRE, we only look at the waves in one direction. So we can only deal with planar waves that travel incident to our imaging field of view. What happens, as you might expect, when you're vibrating a liver with all the structures and stuff inside, the waves get diffracted, refracted, and we end up with oblique waves like this. So if you're only encoding waves in one motion, you're obviously not going to get an accurate description of this wave, which is traveling obliquely. So what MRE does is, or what 3D MRE does, is instead of just encoding this one direction, it changes that motion encoding gradient that you saw in the sequence diagram and the X, Y, and Z direction, and from that we get a 3D representation. So we've applied this in 13 participants, not too many. 5 healthy volunteers, and we also wanted to look at the spleen as well as the liver. So the 5 healthy volunteers, we did single and dual driver. Single driver, we just vibrate the liver or the spleen. Dual driver, we vibrate them both together. And then in our 8 patients, 6 who were cirrhotic, we just did dual acquisition. Now to make sure that the 2D and the 3D were compared exactly, what I did is I took the 3D data, which has 3 directions of motion, and then just inverted the through plane motion to get the 2D. So it means that the SNR is exactly the same, the wave field is exactly the same. So it's the most accurate way that we have to compare the 2D and the 3D. So here's some wave images of the liver only, the spleen only, and the dual driver. The white is a representation of where the paddle sits. And underneath we have our elastogram with our confidence map, which is this grid structure here. So on the liver only, as you can see, the liver is nice and clear. We can take measurements from this with confidence that it's a good representation of the stiffness. The spleen, we don't see anything because we don't have any waves there. Likewise, on the other side, we can measure the spleen, no problem. And the liver, not so much. You might be able to see, I don't know how dark it is, there is a tiny bit of wave motion going on here. The way these paddles work is they actually vibrate the rib cage, and then the rib cage in turn vibrates the liver. We don't actually go to the liver directly. So if you have good contact with your paddle, or if you're vibrating very hard, if you vibrate on one side, sometimes you can get some measurements on the other side, but in general not. So what we do is we apply 2 paddles and vibrate simultaneously. So we get a liver and a spleen measurement. So what did the results show us? So with the 2D MRE, as we expect in healthy people, we get a higher stiffness. So that's because as the wave is traveling through, it's not going to be planar, and the wavelength is artificially increased, so we get a higher stiffness. We didn't quite reach significance, almost there, we couldn't do it. In the cirrhotic subjects, things are a bit different. We saw no significant difference. The means were up and down depending if you're looking at the liver or the spleen. And we were looking into that, wondering why it may be. In cirrhotic subjects, you'll see stiffness is very high. And we think that as the waves are traveling through, there's some diffraction going on which causes the waves to become even less planar than they would be. And in 3D MRE, this is usually not a problem, but when the waves are really diffracted and refracted, the polarization is changing. It causes a problem with the inversion algorithm, because the 3D inversion algorithm, when you have multiple slices, it doesn't just look at its own slice, it looks at the adjacent slice as well and gets data from that. So if there's a really complex wave field, the stiffness may be slightly increased in 3D as well. We have the 2D here on the right. You'll see that a lot of the area, sorry, it's very dark here on my screen. See, a lot of the area here is very purple, which is basically no measurement at all. The 3D, we get a measurement over the whole liver and the whole spleen. And this is a benefit when we go to measure our ROIs. We look at the confidence maps. And we'll see 3D MRE here on the left, 2D MRE on the right. And we see the ROI size is vastly improved. So it gives us a more accurate representation of how the stiffness changes over the liver, which is quite important in fibrosis and cirrhosis because the fibrosis is often very diffuse. It's not localized into one area. So here we have 3D MRE and 2D MRE of the liver and the spleen in non-cirrhotic and cirrhotic. So with 3D MRE, we had a significant increased stiffness in the liver between cirrhotic and non-cirrhotic, not quite there in the spleen. In 2D MRE, we didn't see any significant difference between cirrhotic and non-cirrhotic. And here's an example image of a healthy subject and a cirrhotic subject. And you see how the stiffness can change a lot in both the liver and the spleen. The spleen is kind of an area of current research. There's not so many papers looking at it. It seems to be a predictor of things like portal hypertension or varices, but that is something that once we get our numbers up and we actually have, say, correlation with endoscopy or something like that, that we certainly want to look at. So we also wanted to make sure that when we're vibrating with dual drivers that we're not causing a change in stiffness. Say, for example, if the vibration from the liver is affecting the spleen measurement. And we found no significant difference between. There was a slight trend for the dual drivers to have a higher mean stiffness than the single in all areas, but none of it was significant. And we were happy enough that the coefficient of variation between the 2D and 3D was less than 5% across all the measurements. So we're looking at two organs, 2D and 3D, dual drivers, single drivers, cirrhotics, non-cirrhotics. You think that would be enough, but we decided to look at different frequencies as well. So 60 hertz is the standard frequency that is used in clinics in the US especially. But in Europe, there's a bit of a push to looking at multi-frequency. So we have our 60, 45 hertz, and 30 hertz here. And you can see clearly that they look quite different. The wavelengths are much shorter at lower frequency, and they penetrate much better as well. So we see a profile here across each. 60 hertz gets damped out very quickly. 45 hertz, not so much, and 30 hertz has no problem penetrating all the way through. So if we look at the results of the 3D multi-frequency, we see that there was a significant difference between all the frequencies in cirrhotic and non-cirrhotic subjects. And this is another area that's ripe for future research. I mean, if you were to imagine the plot of the cirrhotic subjects and the non-cirrhotic subjects, the slope is significantly different. But if we were to extend this frequency range, say from 10 to 100, it'd be interesting to see where we hit the peak, where we begin to stabilize. And it could be another parameter that we could use that may be beneficial in the clinic to characterize fibrosis and stage fibrosis. Of course, it does have the drawback that every additional frequency you add doubles the scan time, and we know long scan times aren't that great in the clinic. Another interesting thing we found was that when we looked at the 2D and 3D in the bland Altman analysis, in the 60 hertz and 30 hertz, the red dots here are cirrhotic subjects. At 30 hertz, the 2D MRE was stiffer than 3D MRE. So negative value here means that 3D is stiffer. And in 60 hertz, we see that's not the case. So like I was saying earlier, we think that with 3D MRE, there's a lot of diffraction going on in the cirrhotic case where the liver is very rigid. That's not so much a problem at 30 hertz just because of the length of these wavelengths. They're so long, and the structures that will be causing the diffraction are much smaller than that, that it kind of just rolls right over them and isn't so affected. So what we found was that in the healthy subjects, 2D MRE, the liver stiffness was increased as we expected. In 3D MRE, it was higher in the cirrhotic subjects, which we didn't really expect, but we think that, as I said, we think it's due to the diffraction and polarity changes in the waves. And the 3D MRE algorithm, which is generally a benefit, giving you a more accurate representation of the waves, is a bit of a downfall in this case, because when the polarity changes and the interslice discontinuity, causes an increase in the stiffness. Multifrequency MRE may provide frequency-independent parameters, which would be great because the stiffness changes depending on what frequency you're looking at, but it takes longer to do, so we don't know if that's going to fly, but it's something we really want to look at, even as a research application. Some limitations of our study, obviously 13 subjects, very small sample size. A big one is the lack of biopsy. All these cirrhotic patients were confirmed through MRI scans. There was no actual pathology. So the stiffness is a bit low in some cirrhotic subjects. Usually expect between 5 and 6 kPa. Some of them had 3 to 4. So in the future, we'd like to have an actual gold standard reference to make sure that we are staging these people accurately. Another thing is that in cirrhotic livers, because it's stiffer, the waves penetrate deeper into the liver. And so we want to do the dual driver experiment that we did on the healthy subjects in cirrhotic subjects to make sure that we're not going to cause a change in stiffness depending if we're looking at single or dual drivers. So in conclusion, we think that 3D MRE is a viable alternative to 2D MRE. I think any time that you're getting a more accurate representation of what's happening inside the body, it's better for the clinicians. And in future work to model the response to the frequency and assess whether the cirrhotic patients are going to have a problem when we use the dual drivers. I'd like to thank the TMII group, they're all there looking lovely, for all their help, and thank you for your attention.
Thank you, Paul, for that outstanding talk. This is very, very important work. The non-invasive detection, staging, and quantification of cirrhosis and portal hypertension are really, really important. Any questions?
Hi. Thank you for the presentation. Very nice. I have a question. How long is the acquisition of the 3D compared to the 2D? And whether you think it's more reliable because you have more data and you are having better SNR, or it's because you're really capturing the wave in 3 dimensions?
Well, the image acquisition, generally, at the moment, it's mostly done using a gradient echo sequence, which takes 1 minute to acquire 4 time steps. So the trigger is changed 4 times. We've started using EPI here because in 1 minute, we can get 3 directions and 32 slices. So we get much better coverage. We think that the 3D is much better because you have to take less assumptions in the model when you're doing your inversion. So for example, with 2D, we want to look at shear waves, but there's always longitudinal waves in the image as well that in 2D they're just kind of filtered out, and it's a kind of a broad filter and you lose some useful data. Whereas with 3D, you can just take the curl of the field and it removes it straight away. So 3D is mathematically more robust.
Thank you.
No problem.
Thank you very much. We have this certificate to present to you.
Great. Thank you.